Okay, so the next presentation is by Maura Dandri. She is a professor in Hamburg in Germany and an expert on using some of the best available animal models for studying the complexities of HBV infection in a whole organ. And she's going to give us a talk about preclinical evidence for combination strategies. Maura?
Thank you, John, for this kind introduction. Yes, actually I was asked to give an overview about the preclinical evidence we have about combination strategy, which I actually think is not a very easy task to achieve, also considering the time I have. And also because if you just have a look at this table, you realize that we have actually a huge amount of different compounds that now are emerging that are in the pipeline and even achieve, many of them, the clinical trials. Of course, there is the main concept to use agents targeting directly the HBV life cycles and also agent targeting host immunity. Regarding focusing on the life cycle, we know that we have targeting the entry, the viral entry, the step of entry of the virus. We are working on, we heard from ITAU, what type of possibility?
Please go into presentation.
Oh, sorry. Better,
Excellent.
right? You should tell me. You did. Okay, so now you can see better the table. Doesn't help too much because there is a lot of stuff on this table, but just to focus on the fact that you have different, we can, as agent targeting HBV, act at different level of the HBV life cycle. So, yeah, the entry was mentioning, cccDNA formation, amplification, stability. It's a really different, it's a challenging step using direct antiviral drugs, and ITAU addressed this step as well, and we'll come back just a little bit on this. But we have different options to stop replication at different level, especially if we look at using drugs that reduce the level of RNA transcript, the step of encapsulation, capsid formation, the reverse transcription. Of course, we have since many years potent nucleotides analog, but also new advances in relating to the possibility to inhibit S antigen folding and release. And of course, we have a good cocktail of immune modulatory substances, as we heard also from Adam. So I will have actually time just to pick some of these where we have data of combination therapy and drugs that are quite most advanced also in the development. But let me remind you just briefly what are actually our major goal of the current strategy to cure chronic HBV infection. Of course, we want to reduce liver inflammation, prevent development of cirrhosis and hepatocellular carcinoma. But to achieve, we want to achieve sustained suppression of serum HBV DNA, also post-therapy now, which is considered as partial cure, and with loss of S antigen, which would give us a functional cure. I think that actually where we want to go is to achieve a substantial reduction of serological negativization of actually all viral marker and nucleic acids, so HBV DNA, HBV RNA. And to achieve this, I think we have to keep in mind the situation, how is with the level of cccDNA we have, since this is the molecular basis of HBV persistence. So to lower cccDNA loads and activity, I think it's necessary to achieve these goals. And we know also from patient study that actually high level of cccDNA are more likely associated with the relapse after stopping therapy, while lower level of cccDNA might favor, might increase sustained viral response of treatment. So what is the rationale of using actually an entry inhibitor, agent that block the entry in chronic infection? This might be actually more and more become logical important if we think that we don't have all hepatocytes infected in the liver in some situation of these patients. In preclinical study, we have seen actually that we have the biliverdin, the miclodexp entry inhibitor binding to the NTCP block very efficiently both the entry of HBV and HDV. viruses. And also if given to the humanized mice shortly after, a couple of weeks after starting the infection, we can see that we nicely freeze down the situation. We don't have intrahepatic spreading of the virus and not increase of viremia. And in other words, which seems trivial to say, but actually we avoid cccDNA establishment in uninfected cells in the liver. But also what was interesting to observe is that what we observed actually that the intrahepatic cccDNA load didn't actually increase during the 6 weeks of biliverdin administration, which might suggest that actually this intracellular amplification of the cccDNA pool might be quite inefficient, at least in stably infected human hepatocytes. Of course, we don't know if the recycling, the so-called recycling pathway, might actually be more active and play an important role when to counteract cccDNA loss, and also how stable actually are individual cccDNA molecules. So that's how Aitao was also mentioning. I think that the longevity of the individual cccDNA molecule and also the efficacy of this re-entry pathway actually can really impact the size and the fate of the cccDNA pool in the liver. But keep in mind that not only entry inhibitors, but also probably very potent neutralizing antibody might also hinder not only might also hinder new infection event and therefore contain the viral infection in the liver, and of course reduce S antigen level. But the old concept that we had years ago, if we have really strong suppression of HBV replication production, also achieved by NUCs, actually this can also hinder limiting new infection and reinfection event, and long-term impact also affect the cccDNA pool. So, but we know that NUCs alone actually are not really able to completely block intracellular rcDNA synthesis. This has been seen in patients, and also with a recent study from Gilead has shown that the circulating virion are also infections in humanized mice. So this tells us that we need combination therapy to suppress HBV more potently. Now, based on preclinical evidence and based on the mode of action that we know that with nucleotides analog, we don't reduce HBV RNA level. This has been shown in transgenic mice, humanized mice, and also patients' data. And this drug per se don't reduce S antigen level. If we go to the capsid inhibitor now, we act a little bit earlier. We already block pregenomic RNA encapsidation and capsid formation. So in studying in the hydrodynamic model showed us that actually only after 7 days of treatment with CAMs, we can nicely reduce the level of HBV DNA in serum and in the liver. And from the in vitro study, what Aitao was also mentioning, actually we have to keep in mind this dual mechanism of action of CAMs, which actually not only suppress HBV replication in infected cells, but might also hinder the formation, at least when giving a time of infection, this at least at the in vitro experiment, because they also inhibit disassembly. And because of the mode of action, we also reduce HBV RNA in serum. So if we combine this drug, NUCs and capsid inhibitor, this again, preclinical evidence in humanized mice showed that we have synergistic, we have a strong reduction of HBV DNA in the serum, when the red lines show the data of mice that were treated in the combination with GLP-26 and entecavir, in comparison to the mono treatment, the monotherapy. But again, we also have interferon, which I know clinicians don't like for obvious reasons. We have a side effect, but if we know that we have not only the interferon at not only immune modulatory effect, but also can actually reduce all HBV marker even in immune deficient mice. Like this, again, study in humanized mice from different groups have shown, and also in vitro, that we can actually, because of epigenetic in regulation, destabilizing RNA-containing capsid, we can see in serum a reduction of HBV DNA, S antigen, and E antigen, and what I would like to point out, reduction of the different RNA. And performing RNA in situ hybridization more recently, Lena Alvarez showed us that actually we have a strong reduction of HBV RNA level in the liver of humanized mice and the comeback of the SMC complex. So if we combine interferon and capsid inhibitor, these are the relatively old study now from with the Novirac, with the CAMS combination therapy, with in comparison to the antiviral effect achieved in humanized mice from entecavir, from interferon alone, or in combination interferon and the capsid inhibitor. Even here we can observe a synergistic, a stronger effect, which was also seen later on in patients. But the advantage of having preclinical model, we can really look at in the liver. And if you see, at least with this type of compound, with these CAMs, we have seen a reduction of HBV RNA, or pregenomic RNA in serum, but not in the liver. And only PEG interferon could reduce intrahepatic pregenomic RNA. So what also in combination therapy we observed. There is a recent study also indicated, and actually, because of the action of capsid inhibitors, we might have a higher amount of cytoplasmic extracapsid pregenomic RNA, and in combination with interferon, this might increase innate responses. But let's come to another class of agent, a novel agent which has RNA interference, based on the RNA interference strategies. So here we can see if we target all RNA of HBV, what has been observed in patients, and now I'm focusing on the preclinical study, we can see that actually, again, in the humanized mice, we observe a clear reduction of all serological parameter, HBV DNA, RNA, S antigen, just showing here. And also, what was interesting to see that we have reduction in the liver, as expected from the mode of action. And we also could observe in collaboration with Gilead that actually we have a strong reduction of the X protein after 4 weeks of siRNA treatment, but we don't observe change for the time of treatment at cccDNA level. But what was the surprising effect was that actually we could see that this type of treatment enabled the reappearance of the SMC56 complex, its recruitment on the cccDNA and silencing of the cccDNA. Now, let me add the type of add-on study that was done here, which actually, if we stop a siRNA treatment in these immune deficient mice, what we observe is a comeback of all virological parameters. And also the association with the SMC56 complex was gone again. But if we add the entry inhibitor, we were pleased to see that actually in this experimental setting, we could maintain in a large majority of the hepatocytes this type of silencing. And there is an important question which is rising again, actually are new infection events needed to reestablish cccDNA activity? And in this setting also, the recruitment of SMC56 on the complex on the cccDNA was maintained. So we have a mode of action that are expected, HBV RNA degradation, but also achievement of some transcriptional silencing. To sum up this, I would like to say that actually combination therapy, an example given by NUCs and capsid inhibitor, induce certainly more profound viral suppression, but that RNA interference strategy can also reduce all HBV marker, including X, which I personally think is an important therapeutic target to consider. Preclinical evidence indicates that cccDNA transcriptional silencing actually might be achievable as a clinical goal, but of course this has to be demonstrated in patients. And also that shielding, protecting the hepatocytes from new infection event might actually be a key component in the therapy concepts to support silencing, avoid cccDNA amplification. But as Adam was mentioning, actually we need to understand if actually what is the impact of this novel direct antiviral therapy on immune recognition and responses of treatment. And I would like to, at the end, to show what also was, I think, one of the favored type of concept that was proposing also Adam. Well, actually, it's important to understand. Here we have from the work of Ulla Protzer group, which was showing actually that knockdown of antigen expression by a cRNA combined then with the therapeutic vaccine strategy increased the efficacy of the responses of treatment. This was shown in AAV-HBV mice. So to make the final slides, so based on the preclinical evidence we have so far for combination strategy, I think it's actually too early to predict the best cocktail of compound. And safety, of course, remains the main issue. But I think that still NA, so nucleocapsid analogue interferon, are still important as backbone of new combination therapy regimens. And what might be the most logical combination? In my opinion, I think it's very important to combine antivirals that mechanistically act at different stages of the HBV life cycle and which can suppress both replication and viral antigen production. And also we have to keep an eye that consider the cccDNA fate long-term, block of new infection event might actually play a key role. We might achieve a reduction of cccDNA activity. I think the reduction of cccDNA loads takes more time and remains more challenging. The gap, we still don't know exactly cccDNA half-life stability, depending probably of the setting. And also we don't know if novel strategy can favor the recovery of immune responses. So likely addition of HBV-specific immune strategy might be necessary to achieve a cure. Thank you.